Now let's get into some specifics for the newborn visit. This is the first visit with the practitioner after the newborn was born or after the newborn was discharged from the hospital. This newborn visit should happen 3 to 5 days after birth or 48 to 72 hours after being discharged from the hospital. During this visit, you want to gather all of your histories, perform a physical exam, assess feeding, and assess parental concerns. Your screening results should be back. The newborn screening results, they should be back by now if they were done previously in the hospital. So you want to look at those and make any necessary referrals. It is in this visit that you begin surveillance of development. You want to assess social language, verbal language, and gross motor and fine motor development. When it comes to immunizations, you want to make sure that the hepatitis B vaccine was given. This is also a good time for some health promotion, just recommending that all adults caring for the child receives their pertussis immunization, which is the Tdap. As mentioned earlier, the practitioner needs to perform all universal screenings on the newborn. So here's a list of the universal screenings and then any selective screenings that would apply to your newborn visit. By the time the practitioner sees the newborn for their first newborn visit, their newborn screening results should be back. So you want to make sure that they had a newborn screening in the hospital, or if it was a home birth, you want to see, was it done? If it's not done during this newborn visit, it's your responsibility to collect samples to send this off. However, if it was done, the results should be back. By the time you see the patient, you want to review the newborn screening results and make any necessary referrals. Here you see a sample of a newborn screening. Now every state is different. Every state is required to assess and check for different metabolic disorders, different conditions. So feel free to check your state to see what is required to be tested for on the newborn screening. So when it comes to the newborn physical examination, I want you to review the chart in your textbook for common newborn physical findings. It is up to you to know what's normal and to know what's abnormal, because you will have to calm the anxious parents down about physical findings on their newborn. So here's a picture of a normal newborn head with the fontanelles. During your physical exam, you must palpate these fontanelles, and your findings must be included in your physical exam. Now we're going to get into some common neonatal findings. Here I have pictured milia, and these are firm, pearly white papules, and they're scattered around the forehead, the nose, and the cheeks of the newborn. If they occur in the mouth, then they are called Epstein pearls. And these are normal, common neonatal findings, and they can concern parents when they see them, but no treatment is necessary. Here we have sebaceous hyperplasia, which is an overgrowth of the sebaceous glands. And they look like yellow, whitish papules that kind of occur around the hair follicles. And they're mainly on the nose, the forehead, maybe the upper lip, and the cheeks. Again, no treatment is necessary, and they'll shrink and disappear within the first few weeks. The next common neonatal condition is erythema toxicum, and this is characterized by firm yellow to white 1 to 2 millimeter papules or pustules, and they're normally surrounded by erythematous flare. The lesions usually develop around 24 to 48 hours of life, and the lesions are clustered in several sites. Again, no treatment is required, and this will disappear by itself. Here I have pictured transient neonatal pustular melanosis. Again, this looks very concerning to parents, but you just need to let them know that this is a common newborn neonatal condition and no treatment is necessary. Okay, next for common neonatal conditions, we have sucking blisters. So if you'll see to the left of the slide, we have these newborns here with sucking blisters on their lips. As soon as they come out of the womb, you know they're sucking. They're sucking in a bottle, they're sucking on a nipple. So you'll have these blisters that form. But also you'll have some newborns that are born with these blisters on their thumbs, on their index finger, maybe even on their forearm, because infants or these newborns are actually sucking in utero, so they are born with these sucking blisters. And to the right of this slide, we have cutis marmorata. This is a lacy, kind of reddish, bluish, vascular pattern looking rash, or more like a birthmark. And it appears on mostly all of the body of the newborn. And it's due to the vascular changes in response to temperature extremes. So it's when the newborn is cold in lower temperatures, this kind of lacy rash will form here. Now, this rash normally disappears once you warm the baby, wrapping the baby and covering the baby up. Now, if this lasts for long periods of time and it's a persistent thing that's happening, the baby may need to be checked for genetic disorders, because it is seen often in Down syndrome and trisomy 18. Okay, next to the left of the slide here, we have a baby with harlequin color change. So this is a division of the body skin coloring. So the skin coloring starts from the forehead and it goes to the pubis. And on one side of the body, the baby's, red. Definitely see, a bright color of the skin, and on the second half or the other half, the baby's pale. So this cause is unknown. It usually develops between around 2 to 5 days of life, but it has been reported as late as 3 weeks of life. Again, no treatment is necessary, but yet again, this could be concerning if parents see it. And next to the right of the slide here, we have nevus sebaceous. This is a yellowish, kind of hairless, smooth plaque that's typically seen on the head or on the neck, and it results from an abundance of sebaceous glands. To the left of this slide, you have your deep skin dimples, and they can be pits or creases, and they can occur in over any bony prominence of the newborn's body. Here you have one in the sacral area, and you'll see these a lot. You'll see this little dimple in the sacral area. No treatment is necessary, and if it is just an isolated dimple here and there's no other findings, there's no follow-up needed, no treatment is necessary. It's when you find other things associated with this sacral dimple that we worry about things like spina bifida. In the center of the slide, we have preauricular sinus tracts. So these are pits that occur right there on the pinna of the ear. They could be unilateral or bilateral. Normally, these are fine. It's not a cause for concern. However, we do want to confirm that the newborn has a normal hearing screening. So we do want to make sure that the newborn has passed this hearing exam with this. And lastly, you have to the right of the screen the supernumerary nipples. So this is basically just, an extra nipple. The cause is unknown. Sometimes this can be linked to urinary tract anomalies, but it's a rare condition. Again, there's no treatment necessary if this is all that's abnormal in the child. So next we have oral thrush. And oral thrush is basically just yeast, a yeast that grows in the mouth of the newborn. It appears soft in a white plaque. Might be some redness around the areas. So sometimes parents will get thrush confused with just milk. Sometimes milk is just actually on the oral surfaces of the mouth. So how can you tell the difference? If you can easily wipe away the white plaque, then that's milk. If you can't wipe it away, that's oral thrush. Treatment is with oral nystatin suspension 4 times a day. And if the infant is breastfeeding, the mom needs to treat her nipple area to prevent reinfection. Okay, next we have caput succedaneum. which is diffuse superficial swelling of the soft tissue. This is of the scalp. And sometimes there's some bruising also associated with it. So the big thing about this one is that this swelling usually crosses the suture line. So you see the suture line in the newborn's scalp, the newborn skull. The swelling will cross the suture line. So it'll be on both sides of the scalp. And you see here I have a cap for the capit. So a baseball cap here goes over the entire head. So it goes on the right and the left side of the scalp. So it crosses the suture line. Now it can also be localized, but the majority of them will cross the suture line. So this is caused by traumatic birth. It originates from trauma as the baby descends through the birth canal. And it's frequently associated with molding and maybe a vacuum assisted or a forceps assisted delivery. No treatment is necessary for this. The swelling will usually resolve spontaneously the first few days after birth. If there is some associated bruising, we do want to observe the newborn for signs of jaundice, because as that swelling goes down, those red blood cells will absorb in the body, and sometimes that can cause jaundice. Now, we don't want to confuse capit succedaneum with a cephalohematoma. A cephalohematoma is a collection of blood in the subperiosteal area of the scalp, and it can be felt as a bony prominence over the skull. Now, this swelling does not cross the suture lines, and usually there's no bruising associated with it. So this is caused by trauma with delivery, and the swelling will appear hours to days after the delivery. No treatment is usually indicated with this condition. It resolves in a few weeks to sometimes months. Just that calcification of the hematoma, it may require a month or so to fully go away. As with the other, it is important to monitor this newborn for jaundice. Next, we have craniotabes, which is a thinning of the bone of the scalp. This is most often seen in premature newborns, where they'll get a ping pong ball effect when you're pressing on the parietal bone. So this is a normal variation of that parietal bone. There's no treatment necessary because this will resolve spontaneously. If this is persistent and it's pathological, the child should be investigated for things such as rickets. Can you guess this common neonatal condition? It's jaundice. Jaundice is an accumulation of bilirubin in the skin, and it causes a yellow or orange or sometimes even green hue of the skin. So jaundice becomes apparent when the serum bilirubin exceeds 5 to 7 milligrams per deciliter. So there are a few different types of jaundice. First, let's discuss physiologic jaundice. So this is when bilirubins increase, typically around the 3rd day of life, and then the bilirubin will slowly decline around the 10th to the 12th day of life in Caucasians and African American newborns. Newborns of Asian descent, the bilirubin will increase around 4 to 5 days of life, but it will decline more slowly. In non-physiologic or pathologic jaundice, jaundice occurs too early, within the first 24 hours of life, or it's when jaundice persists too long, lasting longer than 10 to 14 days, or it's when bilirubin levels rise too high. If jaundice occurs in any of these 3 conditions, it is considered pathologic and requires attention. So the practitioner will end up doing a workup. Next, there's breast milk jaundice. And breast milk jaundice occurs in any newborn who is healthy and thriving, who has adequate stooling and voiding, and when the newborn has an appropriate weight gain. Breast milk jaundice is broken up into early onset and late onset. Early onset develops within 2 to 4 days after birth, and it's a result of infrequent breastfeeding. Late onset breast milk jaundice develops a little later. It develops around 7 days after birth, and it peaks around the second or third week of life. And this is in infants who have a good appetite. They actually drink an adequate amount of breast milk. Late onset breast milk jaundice will persist in newborns unless breastfeeding is interrupted. So there's no treatment for breast milk jaundice. You're supposed to just continue breastfeeding unless other clinical signs of pathological jaundice are observed. During the newborn visit, the nurse practitioner should conduct a developmental assessment. Motor skill development and communication and language development should be assessed. The nurse practitioner should also assess social and emotional development, along with cognitive and sensory development. When it comes to physical development, the newborn's weight is a major assessment. During the newborn visit, anticipatory guidance should be included. And remember, anticipatory guidance is information on what the family can expect between this visit and the next scheduled visit. This should include information on the newborn's behavior, feeding, safety, and routine care. Remember to always provide follow-up appointments and information in writing.